Hello and welcome to the part 3 of the Bradycardia and AV block talk. In the first part, we talked about the physiology of the conduction system and the normal function of the conduction system. In the second part, we talked about some pathology, about why the conduction system may fail and how to identify the level of the block and how to risk stratify patients. And in this third component, we'll talk about the sinus node and sinus node dysfunction. Now let's talk briefly about sinus node dysfunction. I generally leave this topic towards the end because sinus node problems are generally not life-threatening. They're fairly low risk and they don't lead to cardiac arrest or sudden death. However, they can be quite symptomatic and be quite a nuisance to the patient because they can lead them to pass out or become lightheaded suddenly. We certainly put in pacemakers for sinus node dysfunction, but only if the patient is sufficiently symptomatic, and the symptomatic benefit of a pacemaker has to outweigh the potential risk. So the sinus node is a crescent-shaped structure that sits at the base of the SVC. There it is right here, and it's at the crista terminalis, which is what this gray line represents. That's where the atrial muscle bundles terminate, and there's a couple things that can go wrong with a sinus node. Number one, the cell's automaticity can be altered, and it could be due to intrinsic cell problem or due to autonomic input that can change cells' automaticity, or it could be drugs, as potential examples. And the other thing that could go wrong is the signals that are generated from the SA node has to exit the SA node. Okay, if they cannot exit, then we call that sinoatrial exit block. Just to summarize, there's a number of sinus node dysfunction problems. The only one I'll spend a little bit of time on is conversion pauses because it's very common. The sinoatrial exit block stuff, I have 2 slides of it on the end. For those who are not interested, you can skip that. It doesn't really have a lot of clinical relevance, but certainly cardiology trainees or EP fellows can look at those slides. It's probably about 30 seconds. But we will spend a little bit of time on conversion pauses because they're so frequent. So this rhythm here, at the beginning, you have atrial fibrillation. It's an irregular rhythm with no discernible P wave, so it's atrial fibrillation. And then we have a termination of the AFib, and you have a long pause, and then you have continuation of sinus rhythm. So this is a conversion pause. And this presents a bit of a clinical challenge to manage because any rate control medications generally also inhibit the sinus node and can make the pauses worse by worsening sinus node dysfunction. But stopping the rate inhibiting medications such as beta blockers can make the tachycardia part worse. So this is the classic tachybrady syndrome. I generally, I strongly dislike the word tachybrady syndrome. It's a very layman's explanation of what's happening. It doesn't really help me understand what exactly is going on and what this patient needs. So I strongly discourage people from using the word tachybrady, but describe exactly what you see and what you think is going on, okay? So this is atrial fibrillation conversion pauses, and the main problem is sinus node dysfunction, right? So the sinus node did not kick in when it's supposed to after being bombarded and being in atrial fibrillation. So as before, this is a sinus node dysfunction problem. This is not like an urgent thing that you need to rush the patient to the hospital for. However, it can be symptomatic, and these pauses can be quite long. And if they're symptomatic, I generally treat patients in a more urgent manner because I just don't want them to hurt themselves. If they pass out, if this is more than 5 to 8 seconds, then it comes to the point where they can really harm themselves. And this is often managed with a pacemaker to treat the sinus node dysfunction, and then after which atrial fibrillation can be rate controlled. Or another approach to this is to rhythm control and keep this patient out of atrial fibrillation. Now we'll talk a little bit about the 2 types of sinoatrial exit block. This is mostly for interest's sake. For those who are not interested, this is just sinus node dysfunction, managed the same as all the other types. But for those who are interested, certainly senior cardiology trainees or EP fellows, The first thing I do when I see a pause in the sinus rate like this, I caliper out the P2P interval, and I move it over 1. This is where your calipers become very helpful, because you can move over 1 and see where the next sinus P wave would have been, and it's not there. And then I move over another cycle, and I find that the following P wave comes back exactly on schedule. If the sinus node didn't fire, it's pretty unlikely that it'll come exactly on schedule. So it must have fired, but the signal didn't exit the sinus node and depolarize the atrium. It got blocked. So this is a very classic and common sinoatrial exit block. And we call it like a Mobitz 2 exit block because it's not that it's dangerous or anything like that. It's just, it just suddenly drops a P wave. And very quickly, this is an example of Mobitz 1 sinoatrial exit block, where if you measure the P2P interval, the P2P interval shortens with each successive cycle in the sequence until the P wave is blocked, and then it resets. We don't actually see the sinus node being activated in any of these. There's just not enough myocardium there to show up on the surface tracing. But we see the output, right? We see the P wave. Just like if there is a V block, we see the output is the R wave. And as we discussed previously, during Wenckebach, the R to R interval, or the output, shortens with each cycle of the Wenckebach sequence. And just as here, we see the output are the P waves, and the P2P interval shortens with each cycle in the sequence until it drops. So this is a Mobitz 1 type of sinoatrial exit block. Not that it matters for management, it's just out of interest. All right, so this brings us to the end of the bradycardia and AV block series. Just to summarize the approach, the first step is to make an observation and to frame the problem as a sinus node dysfunction or AV block. Then make a more detailed observation to determine the mechanism of the block or the level of the block, which will help you with the third step, which is to risk stratify this patient. So if there's somebody, for example, has sinus node dysfunction that's asymptomatic, that would be a very low risk patient compared to somebody who has a recurrent syncope and infrahis conduction disease evidence on the tracing. Those patients you would treat more aggressively and more urgently. And so I hope you enjoyed this discussion and have created an approach to bradycardias and AV block. And I urge you to go through some of the ECGs that I uploaded in the quick hitter series, where you can practice this approach, go through a couple of ECGs and then review the solutions to help refine your approach further. Thank you for your attention, and have a good day.